faculty members that are here today to support the program. I'm Jody Weinzettel, and I am the Senior Director of Global Education for the Medtronic Lung Health business. Today's subject is Biopsy with Confidence, Correcting for CTtoBody Divergence. The faculty members will bring you through some objectives today, really looking at how anesthesia contributes to CTtoBody divergence. We'll talk a bit about some anesthesia concepts that we believe are really critical in the procedures that we do. And we also would like to talk about how those procedures will absolutely enhance your opportunity to correct for CTtoBody divergence as you go about doing your procedures. As I mentioned, we have an excellent faculty with us today. Moderating the event for us will be Dr. Michael Pritchett. He is the Director of Thoracic Oncology and the Director of Chest Centers of Carolinas in Pinehurst Medical Clinic. We've got faculty members of Karen Phillips. She is a consulting anesthesiologist, Senior Medical Affairs Director for Medtronic, very busy working in our ventilator business. And then Dr. Scott Skibo, who is the Director of Interventional Thoracic Oncology with the Duke LifePoint in North Carolina program. Very happy to have you here. I am also just going to share here that we've got a QR code that we're going to use a couple times throughout the presentation today. We would love your feedback. All you need to do is hold your camera up to this icon and it will launch a survey for you. Again, we'll show this more than once, so just wanted to make sure to look for this and to please participate. We'd love to hear your feedback. So with that, I'm going to pass the talk over to Dr. Pritchett, who's moderating for us today, and look forward to the event. Thank you so much, Dr. Pritchett.
Thanks, Jody. We're excited to be able to do this today. This is kind of a hot topic out there with papers published on this, even just as recently as yesterday in Chest, and we'll get into some of that. And what we're excited to talk about specifically today is really some anesthesia parameters. So it's not too often that we say, hey, we have a way for you to improve your diagnostic yield and your biopsy success, and you don't have to buy anything. And so, of course, there are things out there that you can buy that, will correct for CTtoBody divergence and can help you in different ways to get to nodules and things like that. But, this is more regarding the anesthesia and the aspect of CTtoBody divergence, describing what exactly that is and what to do about it, specifically with just some anesthesia techniques that don't cost you anything and can actually help you have better success at your biopsies. So we're very excited to have a good panel here today. Our first speaker is Dr. Skibo, who's an interventional pulmonologist in North Carolina, and he's going to talk to you about the concept of CTtoBody divergence and some factors that are involved. And then we'll have Dr. Phillips talk, who's an anesthesiologist, and really get into the details of what this protocol is and how to make it clinically applicable. And then you'll get to hear me a little bit at the end, and we'll get into some panel discussion and Q&A. You can submit your questions in the panel on the right. We'll try to answer all of them at the end. So try to hold off on those, but you can submit them as we go, and then I'll moderate some Q&A towards the end with our panel. So without further ado, I'd like to hand it over to Dr. Scott Skibo.
Thank you, Michael. All right, let's advance a slide here. Shoot, it's not advancing. Well, I took control. Maybe I could have somebody advance the slide. There we go. Okay. All right. So, so my job, first off, is to kind of set the table, right? To convince everyone that there is a problem with CTtoBody divergence and what are the factors causing the problem. Because it wasn't too long ago that we didn't really realize how much things such as atelectasis were impacting our procedures. It wasn't until really, Dr. Pritchett here, who does some work with cone beam, was able to visualize this. And I was fortunate enough on several occasions to be in his lab and visualize it as well. So we started to realize really the impact. And this was a handful of years ago. And so we started to do things before all these protocols started coming out to minimize impact of what we were doing from an anesthesia standpoint, a procedural standpoint, to maximize our diagnostic yield. So I guess I'm having difficulty advancing slides, so if we could get the next slide.
I will help you.
Thank you. I apologize. I don't know. It worked in our practice thing. So, all right. So what is CTtoBody divergence? You know, so everyone gets a CT scan before the procedure, and then there's this time between the pre-procedural CT and the bronchoscopy procedure. So it's really that difference between the static pre-procedural CT, and then you have a patient laying on the table that's a dynamic breathing lung that has dynamic breathing lungs during the procedure. So things are moving around, and it's not the same static picture as what you got. So why does this matter? Well, it has the potential for several negative effects. Number one being it reduces diagnostic yield. So you could swear that you're at where you think you should be, but yet you're not getting a call in the room with your rows. Your procedure time goes up. So we're all trying to be very efficient with our procedure time to minimize anesthesia time for our patients, et cetera. And then if you're not biopsying where you think you are, it goes without saying that you have an increased likelihood of complications during the procedure if you're off a centimeter, half. Next slide, please. So this is a graphic. This is a Medtronic's picture, but this is an example of the yellow being the pre-procedural static images that builds out this beautiful 3D tree of the airways, your 3D map of the airways. And then when you do your registration process, which is in purple, you can see that the difference between A and B is significant. So this is the problem, and this is what CTtoBody divergence is, and this is what's really been plaguing us for years as far as increasing our diagnostic yield with these procedures. Next slide. So why does this occur? So there's both pre-procedural factors, which we're going to talk about on this slide, and then procedural factors. So first off, the way that CT scans are acquired at full inspiration, where the chest wall is expanded and lateralized, is not how the patient, and then with their arms overhead, is not how the patient is when you're doing the procedure, right? So this is important to get a CT scan like this because it helps with airway mapping, but isn't what the patient looks like on the table when you are doing the guided bronchoscopy, when they're at tidal volume breathing where the lung approaches FRC. So again, I published a paper saying that, well, geez, if you have a peripheral pulmonary nodule, the difference in movement of this nodule is about almost 2 centimeters between full inspiration and full expiration. So that's a problem, right? So that's pre-procedural things. So CT scan timing, a paper published in 2016 said, well, hey, the longer you wait between the CT scan to the procedure, the more likely these things are to change. And in fact, 7% of them went away in that study, where it was 53 days on average from CT to procedure. Mucus plugging can occur, changing kind of the airway anatomy, atelectasis, and then pleural effusions as well. Next slide. So this next slide. Shows on the left there on panel A a nodule, and this is a lot of these pictures came from the litany. The multiple papers that Pritchett has published, right? On this subject, and so I certainly owe a debt of gratitude to him because he's one of the people that have really brought this topic to forefront, without question. So you see a nodule is clearly visualized on the pre-procedural CT scan. Well, then time goes by, and by the time you get to the procedure, this patient has an effusion, and that position of that nodule has changed. So therefore, your beautiful 3D map that was constructed on the left CT scan doesn't really apply, and you're going to have significant CTtoBody divergence just because of this pleural effusion occurring. Next slide, please. So then you have what are the things that we can really control, which are the procedural factors, right? So we all know about registration technique. Anybody that's done, any, super dimension, it's important to have good technique for registration. But then the name of the game really is atelectasis and atelectasis prevention. So going back to the 1980s, mid-1980s, there's been papers published that within minutes of general anesthesia induction, almost all patients are going to have some degree of atelectasis. And now this is most important, of course, depending on where the lesion is located. So in the inferior lesions or your posterior locations are going to be most affected by this atelectasis. Now, the good thing is the factors leading to atelectasis. You're going to see Dr. Phillips, Dr. Pritchett talk about the protocols kind of revolves around these points here, which are, you want to minimize. So the things that are going to cause atelectasis are prolonged time to intubation, suboptimal ventilation protocols, high FO2 leading to absorption atelectasis, distal wedging of the bronchoscope, bronchoscopic tools and manipulation of the airways causing local atelectasis, especially right around where you're trying to biopsy. And then, the practice of trying to stage the mediastinum, which like a normal mediastinum, prior to sampling your nodular lesion. So most of us, even dating back years, have been going out in a normal mediastinum, so radiographic normal mediastinum, sampling the nodule prior to staging a mediastinum, just for the sole purpose of reducing the development of atelectasis. And next slide, please. So this is, again, you can see this is, from one of Pritchett's papers. This is, you can see exactly what happens here. And this is, like the papers dating back to the 1980s. So and you have your pre-procedural CT looks great, right? You can, you're going to have a great 3D reconstruction of the airways. And then right after induction, a cone beam CT image was performed. And you can see significant atelectasis posteriorly, right? And then at the end of the procedure, it's even worse. So you can imagine, that this could cause some difficulty or increase the likelihood of CT to body divergence. So minimizing this atelectasis and then other things to correct for CT to body divergence are needed because of these type of this scenario here. Next slide, please. So, how often does this really happen, right? Because one of the things is you don't see this happen on fluoroscopy. So, the fluoro always looks good. In multiple papers now have said, geez, we see it on cone beam. We know that atelectasis is occurring with radial ultrasound, but you don't see it on fluoroscopy, right? So there's been 3 pretty recent papers that have kind of not looked at this, but some of them have looked at this, but like this paper was looking at cone beam CT, like the radiation dosage. But as kind of a side finding of the study, which is 20 patients with the median lesion size at 2.1 centimeters, so 1.1 to 3, so kind of in the wheelhouse of, navigational bronchoscopy. They found that atelectasis was obscured the target that they're going after 20% of the time. So 4 out of the 20 targets, 40% of patients developed atelectasis in dependent areas of the lung. And again, none of this was seen by fluoroscopy. And an important point is they did a second cone beam spin on these patients after recruitment maneuvers in 3 of these patients, right? Increasing the PEEP, tidal volume, et cetera. And none of this atelectasis resolved. So this is an important point because one of the things that's super important is to minimize this, to prevent this from occurring, because once it occurs, it's really hard to fix during the procedure. Next slide, please. And then the Cleveland Clinic group recently published in April a small paper looking at 8 patients with the average lesion size of 26 by 24 millimeters. And, 75% of those patients had atelectasis in the target lung. 3 out of the 8, or 38%, obscured the borders of the lesion. So significantly impacts procedures. Next slide. And then just in the last day or so, the Ilocate trial was released. Now, this was not using cone beam CT. This was using radial ultrasound to assess for development of atelectasis and whether, cone beam CT or ultrasound is better at doing that. There's certainly, more studies have to be done at looking at that. But nonetheless, their findings were that they found a lot of atelectasis. You can see that almost 90% of patients had atelectasis in at least one of the 8 segments that they looked at, where, a third of the patients, 6 out of 8 or more segments developed atelectasis. Again, they made the point that this is not visible by fluoroscopy. So unless you're looking with cone beam CT, radial ultrasound, you're not going to know it's there, right? And so I think we've all, probably been fooled in procedures, not realizing the extent that atelectasis was occurring. And then the other thing that, they make the point, and I think this happens, is that atelectasis can mimic your target, right? So it's not normal aerated lungs. So it can, I think, it's probably easier to get fooled by looking at atelectasis under radial ultrasound, thinking you're at the target and biopsying atelectasis. So I think that's an issue as well. Next slide. So the two things that really impacted the development of atelectasis, according to the Ilike trial, were they correlated with BMI. So the heavier you are, the more you're going to develop atelectasis. And then the time to atelectasis survey. So the way this trial was done is they did their procedure. Then after the procedure, they took a radial ultrasound probe and went out into these 8 different segments, went out until they met resistance, drew it back 3 centimeters, then took their picture, right? And so the average time was 33 minutes, but it varied from 3 to 94 minutes. Why it was 3 minutes is because if there was in the nodule that they were biopsying, they did that part of the procedure first. So anyway, 3 to 94 minutes. So, and the other important point here is no specific ventilator protocol was used. The vast majority underwent procedures with an LMA, 100% FiO2, and 0 or minimal PEEP. So I think this is important because this proves the point precisely, which is, hey, if we're not managing anesthesia in the ventilator appropriately, in the vast majority of times, you are going to get atelectasis. That's going to significantly increase your risk of CTtoBody divergence, which is going to decrease your diagnostic yield, increase your procedural time, and put you at risk for increased complications with these patients. Next slide, please. So again, this is from Pritchett's paper. I might as well just, every slide I guess is from Pritchett. but anyway, so this is how do we overcome it, right? And so, so I have been fortunate enough for the past couple of years to be using fluoroscopic navigation or FluoroNav, and now recently the Lumicide platform, right? And so, fluoroscopic navigation will use digital tomosynthesis reconstruction to augment these lesions so you can see them, and then do a local registration using fluoroscopy and a proprietary algorithm to allow for catheter repositioning. So now the green ball is truly your target. And so that's exactly what this panel of photos is showing. So up in the upper left, you have an AP fluoro shot showing the catheter in place. You can see in the CT scan, it's a right upper lobe nodule, and which is fluoro invisible, as many of these small things are. As the you navigate to it, you think, well, I should be right on it, but you can see in the middle top, you're past it. You do the FluoroNav with the re-registration process, and you can see, yep, indeed, my catheter is beyond it. So now you have the ability to reposition the catheter into what's a position that's ideal for biopsy, which is the real position you should be in. So in my opinion, this has really improved our ability in our cath lab, or in our bronch suite, which is the hybrid OR cath lab, to have success with these procedures. So next slide, please. So I just want to end with, a case, that I recently did. So this is a 58-year-old gentleman with, he had an exophytic sarcoma on his left arm. So found to have this tiny little nodule, 8mm nodule in the left lower lobe, right underneath the rib, as you can see, in both the coronal and axial reconstructions. So the surgical team, the surgical oncology team, wanted to know, hey, is that metastatic disease? Because if it is, we're not going to do surgery on his arm. So, this is right under a rib, and percutaneous biopsy was not an option. This was just from a couple weeks ago in my bronch suite. So if we could have the next slide and play the video. So, we're navigating to this, and, prior to doing the re-registration process, Many of you are, I'm sure, are very familiar with this navigation. And then as we get to this, we'll do the re-registration. We're doing the fluoroscopic navigation, so we're doing the local registration, again, a second registration, to make sure our position is fine-tuned, because this is at a place that's at risk for complications, of course. And then what we wanted to do, what our goal was, is to be able to use the Illumicite platform to not only know where we're biopsying, but make sure we're staying on the medial side of this little nodule so we didn't end up with a pneumothorax in this gentleman. So as we're doing the fluoroscopic navigation protocol, just quickly going through this. And then we're doing our fluoroscopic sweep, where it's, tomosynthesis reconstruction, the proprietary algorithm that I said, as they're reconstructing and doing the, allow us to reposition the catheter. I apologize that it's this whole thing. I forgot that it was this whole thing. And then you mark the catheter, mark the position of the nodule, and now you can reposition the catheter based on the real image. So now we can make sure we're lined up in the position we want to biopsy, and then we take the locatable guide out. And the locatable guide's out now, the Illumicite, which is the smart extended working channel. And we can make sure we're staying as on the, what we made sure in this case is we're staying on the medial side of this lesion. So, this is something that wasn't possible, previously, to be able to not only know that that green ball is the real lesion, but to have that kind of, looking down the barrel of the gun view of it in the alignment view on the top left, and then making sure we're staying on the medial side of that lesion to ensure that we didn't get it or minimize our risk of pneumothorax or complications. Next slide, please. And then lastly, I just want to say, on the tool CrossCountry. So CrossCountry, and I'll be very upfront, I've never used this on a human being in my bronchoscopy suite because, I've only had experience in the pig lab as well as, up at Medtronic. Now, this is a tool that I've always thought was waiting for Illumicite to be developed. So now this tool allows us, using the Seldinger technique, to pass the catheter over a wire in access lesions that are outside the airway or go what's called off-road, right? And so this is a tool that I think now that Illumicite is available, and you can now steer and direct with the Illumicite catheter, it allows us to go after lesions that we previously weren't able to do. So, again, I just wanted to mention this as something that I think now, in my opinion, and in my bronch suite, is going to have a home. So, all right, that brings us to allowing me to pass the torch to Dr. Phillips.
Thank you, sir. Let's see if I've got action. Right. So, thank you very much for inviting me to join this call today. And I want to start out by acknowledging that I'm here on really traveling on the coattails of greats, two of whom are on this call with me today. A lot of what I'm presenting is actually what has been taken from protocols which have been set in place by a number of IPs across the country. And really all I've done is put them together and find anesthesia references for them. So hopefully I will do both these gentlemen and others justice in presentation of these guidelines or suggestions, really. The other thing I want to say that Dr. Pritchett said that you're not going to be paying for anything. And I want to point out that what you are going to be paying for is a little bit of sweat and blood to convince your anesthesia provider that these things should be done. For as much as we are a service discipline and are here to make a surgeon's lives easier and therefore the patient's procedure less onerous and potentially quicker and with fewer complications, there are some issues presented here that are going to require a little bit of negotiation and discussion with your anesthesia provider, simply because they don't generally fall into standard practice. And then finally, we've already heard about what the problem is to be solved, that atelectasis causes significant challenges with visualization of the nodules, and particularly within three-dimensional imaging, those problems can be significant. If your patient is fluffier, if your nodules are in the lower portions of the lung, it certainly makes for a more challenging experience. Finally, I want to acknowledge that this is not a protocol. We're done with protocols. Everybody's sick of them. Everybody sees them. This really is a collection of guidelines, suggestions, if you were, to your anesthesia provider so that they may change their practice in some way to improve visualization. So again, repetition, we're all adult learners. Apparently we learn by repetition. So here's the repetition bit. Atelectasis hinders visibility, and as Dr. Pritchett, Dr. Skibo has very eloquently demonstrated and shown the number of the similar literature, that atelectasis is a common problem. It happens in pretty much all of our patients under anesthesia, and really, for the most part, if they're having gut surgery, it doesn't matter. But if you've got someone trying to visualize the lung, it really makes for a challenging exercise when you're trying to find a small nodule distally in the lung parenchyma. So what I propose is that there are 4 real areas that we can highlight where your anesthesia provider could institute small changes to their practice that would significantly improve visualization for the surgeon and certainly minimize atelectasis for the patient. And they're bucketed into pre-procedure, induction, and airway management, the period of the actual conduct of anesthesia, so the time when, you know, they think you think they're doing the crossword. This is where they're going to have to get involved in this part of the procedure. And then finally, a few notes about the breath hold, the timing, and how it should be done. So moving forward, of all of the suggestions that are to be made, this may probably be the second one in terms of hitting resistance. Even though it doesn't actually happen within the operating room, it might happen in the holding area before the patient actually comes in. But intensive spirometry does a little bit of auto-peep for the patient. It allows expansion. It is used routinely post-operatively in our PACUs to enable and to reinflate the lungs after surgery or atelectasis from routine surgical procedures. It encourages slow, deep breathing and really allows the patient to do a little bit of what the anesthesiologist is going to have to do once the patient is asleep. It also, for some, if you have good compliance with your patients and they're able to perform the technique efficiently, can really give you an idea of tidal volume for these patients. And many of our patients may have COPD. They may have lung volumes that are significantly larger, or conversely, they may have restrictive lung disease and have smaller lung volumes than what we anticipate. This kind of gives us a ballpark figure. But more than anything, it just keeps the patient entertained, keeps them amused, keeps them focused on doing something that we're ultimately, as anesthesia providers, are going to do once they're asleep. Moving on to the induction and airway management part, and really, I think of all the suggestions that you're going to ask your anesthesia provider to institute, this may be hit with the most resistance. Standard anesthesia practice is about taking 5 or 6 VC breaths with 100% oxygen, and traditionally this was done to kind of buy time during the period where we're waiting for the muscle relaxant to work, and during the period of apnea when the patient is not getting anything via the face, is apneic, is paralyzed, and you're taking control of the airway. And then what would traditionally happen is that we would use something like scoline, a depolarizing muscle relaxant, which causes whole body fasciculations, muscle twitches, that pretty much consumes all of that oxygen. So the aim was to buy time at the beginning in order to not lose when the patient started fasciculating. Modern anesthesia practice, however, is based around non-depolarizing muscle relaxants. Generally, we don't use succinylcholine, we use rocuronium, cisatracurium, or whatever else. So if at all possible, ask your anesthesia provider not to start with 100% oxygen as a pre-oxygenation. If the patient sats so low, then obviously this is a non-starter. But what it does do is retain some of the nitrogen splint within the lungs. And really, that's what gets washed out with that 100% oxygen. As we all sit here, most of us are breathing about 21%, slightly less if you're at altitude. And the aim is to displace that and replace it with oxygen that can be used for the period when the patient is apneic. However, what it does is it leaves a vacuum, so that once the patient actually uses up that oxygen, once that oxygen diffuses out of the lung, you then have lung collapse. Those alveoli just collapse down without that nitrogen splint that is evident in all of us as we sit here right now. So rather ask them to flip over and start with a lower FI, even down to 0.6. The references at the bottom are all anesthesia references and specifically speak to how atelectasis is really significantly impacted if you lower your FI from 1 to just 0.6 during that pre-induction period. Once once you have control of the airway and the tube is inserted and the cup is inflated, immediately, if you're not going to be able to convince your provider to use an FI of 1, try and convince them to crank it down as soon as possible after the tube is in and the cuff is up, and to take it down to an FI 0.6 and perform some recruitment maneuvers, really as a means to not only expand the lung, but get some nitrogen back into those alveoli and help with the process of splinting. So during the conduct of anesthesia, there are really 3 things that I want to highlight. One, we generally use TIVA, so propofol anesthetic with muscle paralysis. This is for a number of reasons. With a number of openings and closings and passage of the bronchoscope through the connection, there's a lot of leak that happens. You lose also the patients de-recruit every time you open the circuit. You lose whatever peak and recruitment efforts that you've done, and it's all really lost. So we rather suggest that keep the patient on TIVA so that you're not also spilling out anesthesia gas and contaminating the OR environment. Very few people are using gas anesthesia anymore, but it's worth a call out to really force the issue if you have to. Expeditious intubation with a large ET tube. By large, I mean at least an 8.5, and the reason for this is to permit enough caliber around the tube once the bronchoscope is in so that you're still able to ventilate the patient without pushing up pressures unnecessarily. And also it allows, you know, the tube, the bronch not to get stuck. It's a freer passage, so you have less tugging and less chance of actually unintentionally extubating the patient. So a large tube is always going to be your friend. You're going to have less resistance within your circuit. You're going to have good passage of your bronchoscope and all the other paraphernalia you're passing down the endotracheal tube. And then finally, PEEP recruitment maneuvers. Traditionally, and again, the literature, this is well known within certainly in ICU medicine, that the traditional 4 PEEP breaths at a peak of 40 centimeters of water for a duration of 40 seconds is often not tolerated in many of our patients simply because there is just a hemodynamic compromise. The intrathoracic pressure is so high that it impedes venous return to the heart, and therefore cardiac output is impaired and they drop their blood pressure. So really what you're wanting to do is anything better than what you've got. Most folk are comfortable at 10. I would argue that you should think of it the other way around, and that take up your PEEP, hold your recruitment pressure to the point where you do lose your blood pressure, and then back off by 5 centimeters. Because only then can you truly know that you are expanding those lungs as best you can. It also reverses whatever atelectasis you had during your intubation period, or if you had a difficult intubation and had to find a different device, it just buys you, it gets you back to where you were before you put the patient to sleep. And again, assess the hemodynamics stability with that PEEP. Test the upper limit, because you would be surprised at how high you can go. 10 is really too little. You know, we ventilate patients routinely for elective surgery with PEEPs of 10. It's when you're needing to really expand the chest of the bigger patient, or those patients who have lower lobe lesions where atelectasis really does have a greater impact, you're wanting to maximize your PEEP to improve not only visibility but reduce catheter bounce. And then finally, a comment on the breath hold. And really the timing of the breath hold is important, because many folk squeeze the bag, they crank the vent onto manual, they take the patient off the vent, put it onto manual, squeeze the 2-liter reservoir bag and hold it. And it doesn't require a VC breath, as Dr. Skibo alluded to earlier. How patients do that maneuver when they're in the CT, and what is emulated when you squeeze the 2-liter reservoir bag and do essentially a vital capacity breath, that in itself is going to cause a bit of CTtoBody divergence. So you're trying to mimic the patient at the normal of at the end of a normal inspiration and hold. The second thing is the hold. And you need to allow enough time for that pressure gradient to actually dissipate throughout the tracheobronchial tree. Dr. Skibo has often said that he will ask when pressure is reached and then count, the 1 to 5 Mississippi option, just to ensure that there's that additional period of time to make sure that you have good expansion of those peripheral alveoli, to make sure that that PEEP breath hold maneuver is actually valued and used appropriately. So in sort of summary, the 4 things: pre-induction with some incentive spirometry. During induction, you're going to try and lower your FiO2 to under 1. And as soon as your airway is controlled, you're going to encourage that FiO to stay below 1. During the anesthesia itself, you're going to have a large tube. You're going to use TIVA, an endotracheal tube, and paralysis. You're going to practice recruitment maneuvers prodigiously in order to ensure good lung expansion. And then finally, the timing of the breath hold, and also having the patients to hold it for just those few extra seconds to ensure that you have good visualizations once you're doing your sweep. Thank you very much. And with that, I shall virtually hand the ball back to the Honorable Dr. Pritchett. Thank you.
Thanks, Karin. That was fantastic. Nice details on why we do these anesthesia protocol things, and really the science behind it, which is not my forte. I just kind of say what we found works and what doesn't work, and it's a nice explanation from you as far as the science, as far as why it works and why it doesn't work. We may have a little bit of overlap between some of my slides and some of the others, so I may skip through some of that stuff. But the point is to show you just basically more examples of what you've already seen here. And this was a case where, we were going after a very small nodule. This was actually for a nodule marking case. And so with this, the pressure's on us even more, because if we lose this nodule in atelectasis, then I won't mark it in the right place. And if I can't see it with cone beam, then I won't mark it at all. And then the patient whole case is canceled. Their surgery is canceled. They can't mark it because we can't find it because it gets lost in atelectasis. So these things are very important and have implications not just for diagnostic yield, but ideally we want to be able to avoid interruptions in their care, additional procedures, and things like that. So we calculated the divergence in this case. It was 2.4 centimeters. So 2.4 centimeters is a huge divergence when you're talking about a nodule that's 6 millimeters. And so, that's a significant proportion of the diameter of that lesion that you're now off by. So what types of bronchoscopy should this anesthesia protocol apply to? The short answer is D, all of the above, okay? Whether you're doing electromagnetic navigation bronchoscopy, robotic bronchoscopy, either EMB robotics or shape sensing robotics, if you're doing thin scope or ultra thin scope with radial probe, if you're doing cone beam, if you're doing body vision with augmented fluoroscopy, it doesn't matter. Any bronchoscopy that you do to diagnose a peripheral nodule, you should absolutely be using this protocol because you want things to be where your computer thinks that they are. Now, some of these technologies have, built-in technology to overcome that. So with FluoroNav, you can overcome that a little bit, and if it's moved, you can fix it. And with cone beam, you can fix it. And with body vision, there's AI, and you can fix it a little, but to a certain extent. As Dr. Skibo pointed out earlier in the paper by Roberto Casal's group at MD Anderson, once you lose that nodule in atelectasis, you can do all the recruitment maneuvers you want. That thing is gone. You're not going to get rid of that atelectasis in that procedure. And I'm very glad that they put that line in that paper, because that's something that we've seen for years with cone beam. And again, the new paper, we'll talk about that a little bit, was really focused on radial probe detection, which is not quite as sensitive. So how do you get this protocol started, right? So Dr. Phillips talked about that. You really just need to talk to anesthesia. You need to involve them and their team, the CRNAs. Explain why this is so important. I have talked with lots of different anesthesiologists, both at my hospital and I've gone to other hospitals. This has been widely embraced at academic centers and in community centers. We haven't really gotten anybody looking down our nose at us and say, well, you just mind your business down there and I'll take care of this up here. They're actually excited to be part of the team, and to have, a stake in this procedure. And so I haven't had any pushback from anesthesia whatsoever. They're always interested in learning why this is important. And usually they say, oh, that totally makes sense. Provide them with written information about the protocol. And I'm going to give you some stuff here that will do that. And again, this isn't Medtronic's protocol that, they're not necessarily allowed to have prescriptive things. They can give guidance, certainly, but we've made a protocol that I'm happy to share. We've really made this open source and wanted to share it with everybody. We didn't want to hog it in a publication and not tell anybody. We've freely emailed this out to anybody. And I just put it on Twitter yesterday too. Discuss the case with everybody before each case. So typically my anesthesia group is really good about coming to me, in the pre-op holding area before every case and saying, all right, what are we doing today? And the answer is, yeah, we're doing the protocol, but there's sometimes where it's even more important, or I'll change things up. So if I have a patient with, a BMI of 42 and a 1 centimeter lesion that's posterior on the diaphragm, I'm going to come to them first and say, we can't screw this up. We get one shot at doing this, and we need to follow the protocol. And not only that, I want a higher number of PEEP. I want 12 a PEEP. I want 15 a PEEP on this case. And I'll get into the exact protocol in a little bit. But again, it's more important on those obese patients and those with posterior or lower lobe lesions. But again, talk with them before every case. It takes 2 minutes. Print out a copy of the protocol, have it with them. And our team has gotten really good at this. I've come into a case and I've seen a brand new CRNA that I've never seen before. And at first, my heart sinks and I'm like, uh-oh, this is going to be trouble. They don't know the procedure. My anesthesia team has literally printed off the protocol and handed it to everybody who comes into one of my cases. So when I walk in the room and I look at them strange, she just picks up the protocol and is like, I got this. And then I'm not worried. And the case goes really well. And so there's no reason that, everybody can't do that. So here's our protocol. I really didn't want this to come out one at a time, but I'll get it all on the screen here so that you can do a screenshot or do whatever you want. Hopefully I won't go too far. Okay. All right, so you could argue that this is a little over the top. And there are certain parts of this, like doing incentive spirometry in the holding area and nebulizers, that you probably don't have to do. But what that does is that helps us. It gets us more recruited alveoli and more open airways so that if we run into problems, maybe we have a difficult intubation. It happens. And that's dead lung time. With you're bagging the patient with 100% oxygen because you had a difficult time, and or you put it in the esophagus or whatever the case may be, difficult intubations happen. So yeah, you don't need to do absolutely every one of these things, but there's an intentional overlap there. Okay. So we do incentive spirometry in the pre-op holding area. We also give them nebulizer treatments so we can dilate peripheral airways and be able to drive out there farther easier. Typically, as a guide, we use their maximum IS guide to set the volume on the ventilator at about 10 to 15% above their max inspiratory volume. That tends to be between 10 to cc's per kilogram. We do rapid intubation. Again, we're not talking about rapid sequence intubation, but we're talking about no messing around. Don't bring in your med students and say, hey, does everybody want to look at the vocal cords on this one? Or everybody want to try to get an intubation attempt? These aren't the cases to do that in. So we want quick intubation and use. Actually, there's studies that show that if you use positive pressure just during induction, when they have that bag on their face, it's not usually tightly sealed and there's no PEEP on it, but just adding PEEP during the induction has been able to prevent atelectasis. You saw in some of the pictures that Dr. Skibo showed that we're seeing atelectasis immediately after intubation in some of these cases. And so it's not unheard of or crazy to use it even during induction. As Dr. Phillips mentioned, we want to use the largest endotracheal tube possible. We typically use 8.5 in women and 9 in men. Will the scope go through smaller tubes? Of course. I mean, the robotic will go through a 6.5 ET tube, but we want to be able to get flow around that tube and not block it, and that will also keep the airways open. So that's very important. we prefer an endotracheal tube over an LMA because once you start getting the PEEP up above 8 or 10, an LMA is not going to provide you the adequate seal that you really need. And I think you saw that, in the Ilocate study with Dr. Casal's group, that they used an LMA in that case. How much that contributed to their atelectasis compared to some of the other factors is unclear. After intubation, immediately get the FiO2 down to the lowest possible level, usually 30%. And always, I don't mean to offend any anesthesiologists when I say that, but keep them honest. They've got a lot of stuff going on, and sometimes they may forget to set the FiO2 down. There's a lot of things that they're doing. So just kind of look over the shoulder and say, oh, you know what, we're still on 100% and like 2 of PEEP. Can we just change that and get that up? And they won't mind. We use paralytics as Karin mentioned earlier, particularly in our lung patients. Now that there's Sugammadex, we're not concerned about that. We can fully reverse them very quickly and not have any respiratory issues. We use a minimum of 10 of PEEP in all of our patients. It does not result in a higher incidence of pneumothorax. If they're an obese patient, we'll go to 12, sometimes 15. And again, you can use recruitment breaths on top of that if you really need to. I mentioned before higher tidal volumes. And then during your breath holds, so if you're doing cone beam CT or if you're doing fluoronav spins, you're going to need to do a breath hold. And so you dial in this little valve that there's a picture of right there. That's the APL valve. You want to have your pressure dialed in before you flip that switch, have the bag full. Look at that ambu bag that's attached to the anesthesia machine. That kind of represents what the alveoli look like. And so if that's nice and full, then you know that that patient's getting adequate positive pressure to those alveoli and they're staying open. Give the adequate time after the breath hold initiates. We typically do 5 to 10 seconds of a hold before we do a spin with whatever. And then, again, this is a hotly debated topic. You can jump on Twitter and see the debate with this yesterday, which is we want you to do navigation first before EBUS staging. Certainly, if there's obvious nodal involvement, you should do EBUS first. But we're going after smaller and smaller lesions. It's like 1 centimeter lesion. The chances of occult nodal metastasis are extremely low. Yes, Hopkins had a series. They did their own data, although they typically biopsy bigger masses and instead of very small ones. And they had 16% occult nodal metastasis. So what that means is 84% of the times you're biopsying the lymph nodes first and you're creating atelectasis and decreasing your chances of reaching that nodule. And that increases your chances that you're going to have to use Vericite, or you're going to have to do a CT-guided needle biopsy, or that you're going to have to do additional procedures. So the nodes are going to be there. They're not going anywhere. Biopsy the peripheral lesion first, and then move forward. All right, so as Dr. Skibo mentioned before, we published this, and this is open source. You can get a copy of this online. Just Google it. There's the reference there at the bottom in the DOI. And basically, all the stuff that Dr. Skibo presented is in here, so you can just look at his presentation too. But, we really sought to look at every platform that's out there and address what each one of them is doing, from robotics to Fluorinav to Varin and everything else, what each one of these platforms is doing to kind of address CT-to-body divergence. We didn't make any judgments. We weren't trying to say this one's better than this one. We just wanted to put the concept out there. But part of this publication was, for the first time, publishing our algorithm or our protocol, what we call the Pinehurst protocol, basically for ventilation best practices for guided bronchoscopy. So this is available in print form, and you can look at this. You can give this one little sheet to your anesthesiologist team as well if you want to do that. So, again, does this really matter? I like to show examples of where it really matters. So this was a very small sub-centimeter lesion, and certainly you saw in Dr. Skibo's case earlier that he presented these very small peripheral lesions where even a little bit of atelectasis matters. And so we were able to navigate to this. This was with Super D, and this is a cone beam image of being right in the center of this tiny little thing. And you do see a little atelectasis down there. You may not prevent it all 100%, but we can get rid of a lot of it. So it really matters. So even small changes will affect that. I put up something from the Ilocate trial as well, which is a pre-proof in chest. This is Dr. Casal's group out of MD Anderson. And this is just a graphical representation of what Dr. Skibo already showed you, which is a ton of atelectasis, particularly in the basilar and posterior segments. And And they specifically said most patients were ventilated with 100% FiO2, and most patients, they used minimal or no PEEP. Their biggest risk factors that they found were elevated BMI and time. Now, why would somebody publish this? Dr. Casal has already known that this causes this, but I think that this is a huge step forward because we have to start somewhere in the literature. We have to start and say, hey, we didn't use any protocol and we got a ton of atelectasis. Yes, we knew it was going to happen, but we had to publish this. And so kudos to them for doing this. They're now working on their second study, which is going to be looking at both radioprobe and cone beam with a dedicated anesthesia protocol to see how much it improves. So we're excited that there is that. So my final thoughts here, and then we'll move to some Q&A. Have a proactive conversation with your anesthesia team. Make them part of your team, okay? Use the protocol for every case. Don't just use it for the hard cases. Perform navigation first. Doing EBUS first increases your risk of atelectasis and will decrease your yield. And get your pre-procedural CT scan as close to the day of procedure as possible. I know that that's easy for me to say. There are lots of insurance issues and things like that, and sometimes we just have to use an old CT. That slide that Dr. Skibo showed earlier of that 1 centimeter pleural effusion that was there, that CT was taken 1 week prior to that procedure. And the patient went into a little bit of heart failure, had a little bit of an effusion, and I caused the pneumothorax in that patient because the lesion was actually 2 centimeters closer to me than I had thought, or than the computer thought. So I drove right past it and into the pleura because of CT-to-body divergence, okay? So get your pre-procedural CT scan as close to the day of the procedure, if not the day of, if you can get away with that, okay? So with that, we're going to open up the panel, and we'll unmute the panelists, and we'll get into some questions here. So the first question that I can see here is, what is the maximum amount of time that you allow your patient to be on this ventilation protocol? We have histoplasmosis in Ohio Valley, and mediastinal anhylar adenopathy is very common, making EBUS unavoidable in the vast majority of our cases. So that one's for me, and then there's one for Dr. Skibo. So I'll answer this. Again, you can keep your patient on the protocol for an indefinite period of time. Obviously, if there's involved lymph nodes, if it looks like we're doing a sarcoidosis case, then I don't use the protocol at all. I just do conscious sedation. I don't care. I'm just doing an EBUS. It's no big deal. It's when I'm using navigation bronchoscopy to try to go after a small peripheral lesion, I'll do that first. And then I'll tell my anesthesiologist when I'm done, okay? So they may keep them like at 90% FiO2 for the whole, not FiO2, but SaO2 for the whole case. And then as soon as I'm done with navigation, I have my diagnosis, I say, all right, protocol off. You can do whatever you want now. You can drop the PEEP if they're having blood pressure problems. You can jack up the FiO2. I don't care anymore. So there is that communication that needs to happen, and that's a really good question. So as soon as I'm done and I have a diagnosis, I turn to them and I say, protocol off, do whatever you want now. Question about Dr. Skibo's case. What difference can you tell from the new platform, I assume Illumicite, compared to the old one? It seems to me that no matter what, there's always an airway leading into that peripheral lung nodule to be biopsied. What are your thoughts on that?
Yeah, that's a good question. If you can think back to that case, everyone plans it out. They make some airway. There wasn't actually an airway going into that case. So how I got to that wasn't in anything that I saw in the CT scan. I used radial ultrasound in that case, which was not helpful. I didn't get a radial ultrasound eccentric or concentric view. And I got a call on Rose on my second pass in that case. I think the first pass was probably a little too medial to it because I was trying to be conservative in that case. So what does the Illumicite platform and FluoroNav do? Well, realistically, it gives me confidence in where I'm at. Confidence to proceed with the procedure in locations that would otherwise make us nervous for a complication. And a lot of times our patients are tenuous, right? And so knowing that the green ball and having that barrel of the gun view, I think to me is huge. Knowing that is reality. And there has been a correction for that CT-to-body divergence. So that's allowed us to do, a lot of cases with success that we otherwise wouldn't have.
Okay, great. So the other question that was asked of me was, and I think we tried to answer this in there, was, is there any increased incidence of pneumothorax when using the Pinehurst protocol? And again, we have not had any increase in pneumothorax at all. We've actually used that protocol even in other trials. So the multi-center robotic trial that we're doing, we're using that protocol. We had 2.6% pneumothorax. So we're not seeing any increased risk of pneumothorax. Krish Badra has been using this protocol for quite some time. He hasn't had any increased risk. Dr. Skibo, have you seen any increased amount of pneumothoraces with?
We have not seen any increased complications, and I would say that we have noticed a significant decline in the amount of passes we're taking per procedure with institution of the anesthesia protocol, because I think we're more likely to get that on-site pathology call in the room pretty quickly versus going back a handful of years, even before we started doing the anesthesia protocol, but doing the EBUS first. And I mean, the procedures were much longer, many more passes, going through many more tools than we're now doing, which is usually a needle and done. So that's becoming more the rule than the exception with these cases.
Yeah, great answer. So I wanted to ask a question to Dr. Phillips, and I guess this is kind of a loaded question, but it's something that I've always asked in my head. So atelectasis in general is bad, especially in post-op patients. We see, COPD patients who have an ortho procedure, for example, and then we get consulted because they're hypoxic on the floor. Would this kind of a protocol be something that could help just general anesthesia patients in general in terms of preventing post-op atelectasis, or does it not work that way?
Oh, absolutely, for sure. And I think particularly, a lot of what we're doing and what we're suggesting here is generally used within, for example, laparoscopic procedures where we're insufflating, gigantic pressures into the belly, pushing up the diaphragm, putting the patients in shoulder holsters and standing them on their heads. I think what we're doing is not unsafe. It's just not generally warranted. And so when we look at how we deal with, if you see how we ventilate patients with ARDS in the ICU, we are ventilating them with higher pressures. We are maintaining them with, within the limits of their own desaturation and their own hypoxia. We're trying to minimize how much FiO2 we're using, simply because we know the role of nitrogen splintage and we know the role of that higher FiO2 in actually promoting atelectasis and rather than discouraging it. So what we're doing is not unsafe at all. As I say, I routinely, for my general anesthesia cases, I ventilate with a PEEP of 10. There is nothing unsafe here. We're just perhaps running slightly higher PEEPs for longer periods of time in combination with higher tidal volumes, simply to facilitate the procedure. But as I say, a lot of this is used in laparoscopic surgery anyway.
Great. So that's good to know. There's one last question, or actually, no, two. So what is the best duration between the date of the CAT scan and the bronchoscopy? Again, in general, as I mentioned at the end, just honestly, as close as possible. Initially they said we want it to be within 30 days if you can. And then it's like, okay, if you can do it within 2 weeks, that's great. We definitely know that there are insurance issues and some insurance companies won't pay for one, especially if, so what happens very often with us is patient has a CAT scan at an outside hospital. They come here, it takes them 3 weeks to get here. Somebody orders a PET scan, so they have a PET scan, and then I want to order a third scan, which is a navigation CT. So sometimes we get some pushback on that. But again, in general, we want to minimize the distance between the day of the CAT scan and the day of the bronchoscopy. If you can do it the same day, even better. All right, there's a couple more questions coming in, and so I'm going to push some of these to Dr. Skibo here, so be ready. Do you recommend higher PEEP to be continued while you're doing your biopsy?
Yeah, so we have not decreased PEEP during the biopsy. And again, I know that's always been a concern dating back to fellowship days. It was went against dogma that you'd never even think about doing a biopsy in somebody that's on PEEP in the ICU, for instance. But I think center after center has shown that can safely be done. So no, we are not decreasing the PEEP during the biopsy or needle aspiration.
Okay. And I would agree with that as well. Again, I think that if I got called to the ICU and asked to do transbronchial biopsies on a patient that's on 10 of PEEP, I'd tell you that you're crazy and I wouldn't do it. But then you think about what we're doing in the OR during these cases, and we're doing the same thing, and there's just really not an increased risk. So no, temporarily dropping the PEEP during a biopsy isn't really going to help you. All right, more questions. How many or how often are you doing breath holds on average? Are you doing them every time you biopsy, or what? How are you doing that, Dr. Skibo?
Well, so for sure we're doing breath hold when we do the FluoroNav or the local registration protocol. So we're doing a breath hold there. Things that are down by the diaphragm, small things of the diaphragm, we'll do breath holds for biopsies at that point. But other than that, most of the other locations in the lung, we're not doing breath holds for biopsy. I don't know what you're saying, Pritchett.
Yeah, I would agree with that. Sometimes even if there's a lot of movement, a lot of times the airway and the nodule are moving together. So, if you do a breath hold, you don't really need to. There are other ones that tend to be in the lower lobes where the lesion's going further away and getting closer and further away and getting closer, like the diaphragm, just like you said, in which case, if on my first few passes, if we're not getting it, and I think that's a contributing factor, we will do a breath hold specifically for the biopsy there. Otherwise, you have to do a breath hold during your FluoroNav sweep. We do a breath hold during our cone beam sweep. The nice thing about both of those is that you can repeat them if you want to. You can redo FluoroNav if you feel like, oh, this has been a long case and I want to just check it again because maybe there's been more movement and things like that. All right. So another question: is there any data or experience with the degree of divergence with spontaneously breathing patients using moderate sedation? I'm not aware of that, because if you're measuring the degree of divergence, typically you have to do a CT or a cone beam CT. If you're going to do a CT or a cone beam CT, you have to have a breath hold. If you're having a breath hold, they're not spontaneously breathing. They need to be, paralyzed. So there are, Mark Bowling was on this call, and I know that there are some people who've had fantastic success at doing moderate sedation, even doing FluoroNav with moderate sedation. I think if you get them deep enough, and certainly some anesthesiologists would argue that once you're that deep, it's technically general anesthesia. But I think you can get people deep enough. But when people are spontaneously breathing, we don't know what their level of PEEP is going to be, so it's better to just control it for ourselves. Another question is, do you do an inspiratory hold or do you do your hold at the end of expiration or at the end of inspiration? Dr. Skibo, do you have a preference on that?
Well, yeah, so the end of normal inspiration, so not a huge inspiratory breath, but just normal tidal breathing inspiration is where we're doing our hold.
Yeah, so we typically do it at peak of inhalation. Now remember, this is inhalation on the ventilator, so you're never going to be able to, with the ventilator, get as deep a breath as the patient took during their CAT scan. And so there's lots of people trying to figure this out, like, all right, should we just do a little bit of a breath hold during their CAT scan instead of a full breath, because it's a little bit closer to what we are doing with the anesthesia machine? We haven't proven that yet. It's certainly an interesting concept. But just in general, we do an inspiratory hold. Technically, it doesn't really matter because you're going to insufflate that pressure from the APL valve. So if you do it at end inspiration, as soon as you switch, that pressure that you dialed in on the APL valve is going to fill the alveoli anyway. So it's just a matter of whether it takes a few seconds longer. Last question that I see here is atelectasis more problematic in the lower lobes versus the upper lobes? What I would say is that it happens in both. It happens to a greater extent in the lower lobe, but remember what your sagittal view looks like on a CT scan, and a lot of that is dependent. So we see in some of these examples and in some other webinars, I've shown the sagittal view, and you can see atelectasis going all the way up to the apex on that posterior wall. So a lot of it is a dependent process, and it will go to the dependent areas even up there. But also keep in mind, let's say you had an apical lesion right here under the clavicle. If you get a centimeter or two of atelectasis at the base, what does that do? That pulls everything down, and that won't necessarily be in the same place. So even if it's not in the exact same place where you're doing your procedure, it can still affect CT to body divergence. If it is in the same area that you're working with, then you may just lose the nodule altogether. So.
Yeah, and I would just add in there, Michael, that you can have atelectasis anywhere depending on how you're utilizing your bronchoscope. So if you overwedge your bronchoscope, yes. If you put your extended working channel, for instance, and you get a really tight seal around that, you are going to collapse the lung right around the nodule that you're working at. So it doesn't matter where it is in the lung. If you do things with the bronchoscope that you shouldn't, or the extended working channel that you shouldn't, you will get atelectasis right surrounding your nodule.
And that's kind of a new thing, right? Like we were always trained, like use the wedge to your favor, like wedge your scope up in there so it won't flip out, you know, when you're doing biopsies and stuff. But then when navigation came along, you know, it kind of changed things because we realized these facts. So that picture, that was a very impressive picture of Krish Badra's that Dr. Phillips put up earlier, as you saw that upper lobe lesion, that the whole upper lobe was atelectatic. That's because of wedging. You know, if it was because of anesthesia, it would be more uniform. That's because you wedged the scope too much and that whole segment collapsed.
Yeah, and never touch the suction button once you're up in the area that you're going to want to biopsy, because that'll suck everything right down. So,
and that's a very good point that really should be kind of almost part of the protocol, although it doesn't have to do with anesthesia. But avoid wedging the scope and don't over suction, because once you collapse those areas, it's very difficult to get them back open.
I mean, you know, I used to, like when I was doing my registration process, our airway inspection, try to get out all the secretions I could, because those are a hindrance and a nuisance. I was using a lot of suction, but that was very counterproductive to what we're trying to do now. So now I just kind of leave it alone and deal with it, because you know, that's minimizing my atelectasis. And so, yeah, I try never to use a suction during a procedure.
Yeah, I think that's a great tip, and a lot of this is really changing the way that we do things. If I'm doing kind of an aggressive clean out bronch at the beginning of the case, I'll do some recruitment maneuvers right after that, because you're exactly right. I probably just dropped a bunch of little peripheral, you know, air sacs. But if there's extensive mucus plugging, that will cause atelectasis too. So I agree with just being cautious, suction as little as possible, and that's great advice. So. All right. Well, there's no other questions. Hopefully we answered all of them. And that's why you don't have any more questions. I'm going to turn it back over to Jody to close things up.
Wonderful. Thank you so much. What an awesome talk from Dr. Pritchett, Dr. Phillips, and Dr. Skibo. Really appreciate your experience, your success here with these anesthesia protocols, and how that's really impacted CT to body divergence and improved your visualization experience. And so we want to thank you for your time tonight. I also just want to share on the QR code here that's attached. If you'd like for us to reach out to you, we are pulling together some one-on-one or small group sessions to talk further about this, as we know there's more questions to be had as we continue to move forward with talking about the anesthesia best practice opportunities, and are happy to help engage some of these KOLs in smaller group discussions along with your anesthesiologist to ensure that you know what you're doing and have questions that we can answer for you, and again, hear from these folks as to their experiences and the dialogue that they've been having. So I want to thank you again for your time tonight. This call was recorded. If you would like a copy, we're happy to help provide that to you. And again, thanks again to our faculty for staying and answering questions, and everybody have a wonderful evening. Thank you.